We're going to move to our lunchtime keynote with Dr. Roberta DeBiasi. When we were planning the agenda and looking at topics earlier in the spring, there were several of us who voiced at least some perspective is like, haven't we chatted enough about COVID? Aren't we done yet? I guess the answer is, much as maybe we want to be, it still looks like there's COVID behind us, but there's still COVID a bit ahead of us. And we wondered who could provide some perspective and framing and guidance about that, and said, well, let's have Roberta do that. So I reached out, and we're fortunate to have Dr. Roberta DeBiasi, who heads up infectious diseases at Children's National, but has been a local and national expert and champion around COVID-19 and pediatrics. And it's my pleasure to have Dr. DeBiasi come to the podium, and we'll get some perspective. Looking back and looking ahead.
Okay. Thank you. We were just saying, maybe this will be the last COVID talk. You know, you never know. So it could be historic. This could be the last time I talk about COVID. I don't know. We'll see. But thank you all for inviting me. And I'm going to try in 25 minutes to cover what's the, okay. I think we'll be okay. I'm going to try in a short period of time, though, to hit the highlights of looking back towards what we really have been through in the last 2 years, and then also what are we really actively looking at right now. And then for disclosures, you know, because we've been really active, we have quite a bit of funding now from several of the NIH agencies, including Allergy and Infectious Diseases, NICHD and NHLBI, including a lot of collaborations with other centers like UCSF and UCSD, as well as our own big studies, which I'm going to tell you about at the end of the talk. And I'm not going to talk about anything that's unapproved. So this is just an overview of what we're going to go through. We're going to hit some highlights of what we've learned about virus and variants and how viruses change over time. What really is the impact on the pediatric population, and is that different from what we expected at the beginning of all this? We're going to talk about our own experience here at Children's National, which has been substantial. And then I'm going to cover the highlights of what we now have done with testing, therapeutics, vaccination, including just the announcement yesterday about, vaccinating our youngest children finally 2 years into this. And then lastly, long-term effects, some of the clinics and research that we're involved in. So let's start with epidemiology. And this is a graph I always show and that you all have access to. It's from the New York Times. They do a wonderful job of summarizing data. I've used it for almost every talk that I've given, which is, every week essentially for the last 2 years. And it just illustrates that we're now in the fifth wave. So this was our first wave of the original strain. We then had an alpha wave, a delta wave, a huge Omicron wave with BA1 and BA2 variants, and now this smaller fifth wave with mostly BA4 and BA5 coming on. But as you can see, we seem to have reached the top of this fifth wave, which is great because we all didn't know if it was going to be another giant Omicron wave or not. So, right now when people ask me, how am I feeling? I'm feeling good. I'm feeling like maybe I could go on vacation now. At least there's going to be a little bit of a lull in the surge of hospitalizations that we've had, and I'm going to show you in a moment. So, variants, you'll read in the paper, oh my God, there's a new variant. It's like a gorilla mutation. It's going to kill everyone. But we all now, I hope, have learned over the last 2 years that this is what viruses do. They've done it for millions of years. They continually evolve and they mutate and they try to become good at infecting as many people as they can. And if you think about it, a virus that doesn't kill its host is better at proliferating, right? If it's good at moving between people, then it's going to take hold and become a dominant variant. So the CDC every week publishes from a lot of labs and hospitals that are contributing samples, including Children's National. What is the distribution of viruses that are going around? And this just shows that if you look back in March, we had predominantly BA1 and BA2, these pink and purple. But now if you fast forward over time each week, look at this, it's just a teeny bit. Whereas back then, these newer strains of Omicron or newer variants, BA4, BA5, didn't even exist. That's the green ones, and they're coming up. And then BA 2.1.2 was a tiny bit, but now that is actually the predominant strain. And we've seen this over and over and over again. You see the one come and surge and then kind of become the last 15-minute news, and the new guy comes along. And we're going to continue to see this. And what we hope is that these variants, as they emerge, will continue to be somewhat milder, like we're seeing now, both from the standpoint of the virus itself and its ability to be very virulent, but also as the population gets more and more exposure to more and more types of variants. This is a dashboard, and I want to call out our CNH data team, Jacob Chang and Thomas Chang. They actually put this dashboard together and give it to me every single Monday at 3 p.m. throughout this entire pandemic. And it's really important because it helps us put in context what's going on globally in the US and in our local region. And I just want to highlight a couple of things on this last one, which just came out on the 20th. Globally now, we've exceeded the number of cases that were estimated to have occurred with the Spanish flu pandemic. So like, this really is historic. This is not just something that we are, going to forget about in a couple of years. And in fact, sorry, I went too fast. Even though the total number of global deaths is not as high as was in the Spanish flu, the number of deaths in the US, which is now over 1 million, is higher than what is estimated to have occurred with the Spanish flu, which was more like 675,000 deaths. So this has been a substantial burden on all of us, which we all know personally, but when we look at this back historically, it's going to be something that is talked about for hundreds and hundreds of years. And then we always keep a close look at new case rates per 100,000 and test positivity rates, and we can follow these trends. For instance, we might see that there's a surge in Europe, and we'll know that it's coming for us in 4 weeks. We've seen that pattern now through at least 3 or 4 different waves. So what we've learned is that data is really important, that global sharing of data is really important, and it's going to continue to be important as we go forward. Now, another kind of data, I'm going to highlight Dr. Song here, who a lot of you know, who's our head of infection control. She, week in and week out, accumulates the number of different viruses that are being isolated. And she is sort of our sentinel person to tell us, okay, we're having an RSV surge or paraflu's coming around or whatever. And what she noticed, and now is, this sounds like, well, yeah, we all know that, but we didn't know this back in March of 2000, is that we essentially had no other viruses circulating whatsoever. And I'm not exaggerating. There was nothing circulating when we were locked down. And when we stopped locking down, guess what? They all came back. So, when we were back here in March, we were all having these high-level scientific discussions like, wow, maybe COVID blocks the receptor for all the other viruses. We were getting all excited about the scientific implications, but guess what? It's just, if you stay away from people and wash your hands and wear a mask, you don't get the other viruses. Now, are we going to do that going forward? Probably not. But we are now seeing right now, I was talking to some folks out at lunch, we're now seeing right now, paraflu, RSV is coming back again. And it seems like since we have reopened from the COVID lockdown, they seem to be coming at times that we don't usually typically think about seeing them. So that has been, I'm sure, a huge challenge for you all in private practice, and probably will continue to be until we get into a more normal flow of our everyday events. All right, so what is the impact on the pediatric population? In March of 2020, and actually even before that, Dr. Song and I were reading all the reports out of China about this new virus, and we were reading that it does not affect children. Kids don't get infected at all. Then we were hearing, well, they get infected, but they're only about, 2% of the problem. Well, we all know now, 2 years later, that kids certainly are infected and can become very severely ill. There's now been almost 14 million cases confirmed in children. And this is the AAP and Children's Hospital Association report, which comes out every 2 weeks. And this is the most recent one. 43,000 hospitalizations of children due to COVID, and that's 3% of all the hospitalizations. So yes, it is much less than the rate of hospitalization in adults, but it is a substantial part of hospitalization, and it's a reason why we need to vaccinate our kids to protect them. There have been over 1,000 deaths of U.S. children, and these are a very small proportion of the deaths, as you're all now aware. But we didn't know that at the beginning. We didn't know what we were going into, so we've learned quite a bit. Then we had to face a new disease, MIS-C. There's now been 8,500 MIS-C cases in the United States and 69 deaths. And we now have gone from, I remember the first days when we were on conference calls with our colleagues in Europe who were just describing these first weird cases that looked like Kawasaki, but the kids were going into shock. And all of us across the country were on the phone together trying to figure out what the heck this was. To now look at this 2 years later, we have CDC data that shows us a clear pattern. If we get a wave of disease, 4 weeks later, we get a wave of MIS-C. And it's happened with every single wave. And we've seen this nationally. We've seen it in our own hospital. And it's gotten to the point where our MISC task force, we kind of know that we need to bump up our meeting schedule. And we can pick the date that we need to bump up the meeting schedule because it just happens like clockwork. One thing we have seen with the MIS-C is that as more and more kids get vaccinated, the number of cases seems to be less. So MISC clearly is a protective, vaccination is a protective effect for preventing MISC. And what we also learned is that MISC was a little bit different. So it was more of the middle groups that were affected by MIS-C, whereas COVID, we seemed to have the younger kids and the older kids most affected. And we also learned that the African American and Hispanic groups, which are these two bars together, are about 60% of all of the MIC cases, and they were also very overrepresented in our overall COVID hospitalizations. But Caucasian children were also affected. So what about at Children's? Now this is actually a report that comes out every single day. I'm not kidding. Every single day we look at a report about, what's going on, and we look for trends. So we've now had 9,000 kids that are actually symptomatic that have walked through our doors, either a clinic or the hospital, that have needed care. And we had a peak of 24 admissions per day when we were in the middle of the Omicron surge. So that was sort of the worst part of this pandemic for those of us that are taking care of the kids in the hospital. We've cumulatively had 1,600 of those admitted kids. And what's been interesting is throughout the pandemic, about 1/3 have needed critical care support and 2/3 have not needed critical care support. In this last little Omicron fifth wave, I would say it's skewed a little bit more towards the acute care. So right now we have 12 kids in the hospital and they're all acute. No one is in the ICU. And again, that's that same theme that I just talked about, where either the virus is a little bit milder or as people have more exposure, they tend to get not as sick. And that's true for children as well. And then multi-system inflammatory disease, we've now had 225 cases at Children's. We've managed these in a very specific way, which has made it a very valuable cohort to follow over time. And at our peak, we were getting 3 to 4 of those admissions per day in some of the waves. So this is a nice graphic, and I meant to type her name in, but I'm going to say her name, Emily Ann Cecina, who is our ID main clinical coordinator, but she is also the builder and maintainer of the entire Children's National Clinical Database for all COVID and MIS-C. So anyone that needs data, Emily is always willing to help them get our centralized data, and she puts together these beautiful graphics. So this just shows you our admissions all the way from March of 2020 all the way through last week, and you can see that the red are the critically ill and the blue are the acute care, and you can see that sort of 1/3, 2/3 pattern with the reduction in the critically ill now. But look at how big this Omicron surge was compared to Delta, which we thought was big at the time, and how little, the original wave looks, even though we felt all overwhelmed by that initial wave. So we'll see if, hopefully this is the last wave, but most likely it won't be, but we'll get through it just like we did everything else. Now, one thing, because we've been so coordinated and worked together in these multidisciplinary teams, is that we were able to publish while we were taking care of these patients with an unknown disease. And we actually were early leaders in alerting other centers. So when we started seeing really severe kids in the DC and East Coast area, there was really nothing published that said kids could get really sick. So here we had the rest of the Midwest and even the West Coast thinking that, well, I don't really have to get too ready for this in the hospital. So we quickly put together this paper, and it ended up being a very important report. And this was the one that showed that it was the children under a year of age and over 15 that were more likely to be hospitalized, which is shown in the red bars, and that it was the kids over 15 that were more likely to be critically ill, shown in the green bar. There's a lot of other things in the paper, but I just want to give you a highlight of what I think are some of the important things that happened over this 2-year period. The leadership that we showed with MIS-C has also really been valuable, not only for defining what MIS-C is in a very defined patient population, not with 1 or 2 patients, at each center, but in a single cohort. but also we had a standardized protocol, which we all put together and followed very closely throughout this whole 2 years. And that's really established this really nice 225 group of kids that were treated in a systematic way that's really going to be able to be followed over a long period of time. And this group of people still meets every 2 weeks. It's really encompasses all the specialists. And we also had an email, which all of you have access to. If you have a kid, you just write MISC task force and it immediately pings to all of us who are the leads from each of the specialties. Now, beyond these general papers, each of the specialists then have developed really important data and shared that with the world. So Ashraf Harshe from our cardiology group, who's the lead point person on the task force for cardiology, published this really beautiful paper, and I love this graph. It just shows you the whole range of cardiac involvement that can happen in MIS-C. And in this time point, this was about his first 40 kids that we took care of, and half of them had a cardiac finding. And at that time, we didn't know, like, was this going to be more severe than Kawasaki? Is it going to be less severe? Is it going to go away? Are these children going to have permanent heart failure and need transplants? We just didn't know. And what this early paper showed was that kids could have any of these different things, including heart failure, coronary artery abnormalities, valvular dysfunction, a variety of things. They could have one of them or they could have multiple of them. And when he published his early follow-up data of these kids, it was very reassuring, because even if they had these things at the beginning, over time, no matter what it was, they seemed to go away. And we've seen this now, in multiple centers, that as overwhelming and severe as MIS-C can be at the beginning and when they're in the ICU, they tend to get better in a short period of time if we intervene really quickly and prevent death. Okay, how about testing? So these are slides Dr. Megan Delaney, who's our chief of lab medicine, put together. Okay, the partnership with the lab is just, I can't even tell you how valuable that is, because what they have done in a short period of time, which she tried to summarize in one slide, really has helped us be on the lead edge of predicting what's going to then happen in the patients and be ready. So I call this the frontier days. On March 6th, when we first started having cases in the US, there was no way to test, so we had a pager and we would have to go through each case coming into the ER, decide if we could test or not, if we should or not, because it's a very precious resource. We had to send it out and get it back in 3 days. I mean, can you imagine, now we can all test at home. But very rapidly, March 6th, 13th, 15th, we went from not being able to test at all to having our own in-house PCR with a rapid turnaround. We had our first patients and employees. We then built a huge walk-up, one of the first pediatric dedicated ambulatory walk-up, drive-up testing centers. And in some of the surges had up to 30% of those kids positive coming through that testing center. And then by April, so this is just, 2 to 3 months later, we now had 4 different in-house PCR platforms. We had our own in-house antibody testing, which was really valuable. There was a supply chain issue. We couldn't even get reagents. Our CRI team, Dr. Villain, made reagents, like they made it, so we could keep going and do a lot of testing. And that allowed us then to commence testing for your CPNA practices. And we were able to help other people in our community, not those just coming through the ER. We also launched, we being the lab team, launched a biorepository. So we now have a very large biorepository of patients that can be used for other people's research questions. And we also launched some exploratory saliva testing with a very interested donor who wanted to be able to expand testing out into the community. And now, if you flash forward, we can now do in-house viral sequencing, and we can tell when some of these new variants are starting to hit our population locally. We now can do pre-surgical, preoperative testing. So all of this happened in a really rapid and coordinated way. And the way that it's shared, and this is very busy, but all I want you to see here is Dr. Delaney, just like Dr. Song and the other data people, share data with us every single day and week so that we are on the pulse of what's happening. And what we saw was that in each of these waves, when we got up to around 13 or 14, 15% positivity, we knew we were kind of getting towards the top. Now, of course, the exception to that was some of the Omicron waves where we got a little bit higher. But this was really helpful to be ahead of the curve, meaning ahead of the curve of the patients starting to come through the door when we could see what was happening. And furthermore, as these variants were described globally, Dr. Delaney's team could then identify them in our own patients, and they were very much on target with the timing of those. What about vaccination? any of these topics could be an hour each. So I'm sorry if this is very high level, but I'm just trying to give you a little bit of perspective like we talked about. Where are we now with vaccination? So if we look at the US population, and this is CDC and New York Times puts together the nice graphs of the CDC data. We have 78% of people that have had at least one vaccine. We have 2/3, 67%, that are considered fully vaccinated with a primary series of some kind, but we still only have about 30% that have been boosted. And we have learned more and more as these variants come about that if you're not boosted, your antibody really does wane quite a bit. Now, we have also learned that T cell or cellular responses seem to be pretty strong, so that even if your antibody levels are waning, you probably, if you've been fully primarily vaccinated, or even better, if you've vaccinated and then get exposed, you seem to make this broader immune response that may be more durable. And that may be why we're seeing people not seem as sick, even though they're fully vaccinated and getting a new infection, that we don't see the rates of hospitalization and death that we did before. But if we drill now down by age group, our 65 and up, we have 91% that are fully vaccinated. Our 18 to 64s are 73%. 12 to 17 is even pretty good. My eyes are not so good anymore, 60%. But our 5 to 11s, even with that being available, we only have 30% uptake. And we're going to talk about on the next slide, what do we expect for uptake for this younger age group? We hope it'll be better than this because, as we pointed out, some of the younger kids are the ones that are ending up getting hospitalized from our prior waves. And then boosters, we're really not doing very well in our kids under 18. Only 6% have had a booster. So as you saw in the news, we now have approval for 2 products. And I used the ACIP meetings that were just coming up as an excuse for not turning in my slides, because I didn't want to give you all information that was going to change in 3 days. And, I thought the ACIP might put a little bit of opinion about they are equal and they are recommending these equally well. There's not like one group you should give it to and one you shouldn't, but I thought sometimes they will give a little bit more context to when you might pros and cons of certain special populations. And in fact, they did do a little of that, so I'll explain that in a moment. But the bottom line is both the Moderna mRNA vaccine and the Pfizer mRNA vaccine are approved now, and we are going to be giving them. The Moderna is a 2-dose primary series using 25 microgram dose of the vaccine, and there's a 4-week interval between the first and second dose. And the efficacy that was presented was age-related. So the youngest kids, there was about a 50% efficacy, 2 to 5, 35%, and overall was about 42%. But you can see there are very wide confidence intervals. So we don't know from a small, relatively small, meaning not out into the real world yet in millions of children, if this is going to be on the lower end or the higher end. But it met the efficacy endpoints for approval, and that's why it was approved. Now, Pfizer is for 6 months to 4 years of age. It is a 3-dose primary series using a smaller dose, 3 micrograms. And dose 2 is given 3 weeks after dose 1. Dose 3 is given 8 weeks after dose 2. And again, efficacy, 6 to 23 months, about 38%. 2 to 4 years was 82%. Overall, 80%. So I'm sorry, 6 to 23 was 75%, 82%, and 80.3%. Now, Moderna did put forth some other data with a 3rd dose that suggests that when you get your 3rd dose of Moderna or a booster, which will be down the line sometime, they probably will also have similar efficacy. And we can't compare these head to head because there were different strains circulating. You cannot compare these both head to head. So your takeaway should be that these are both approved, they're both safe, they both had very few side effects that were of any concern, and that they both met the efficacy endpoints. What else is coming up with vaccines? We're still waiting for lots of interesting studies that have done mix and match approaches, meaning combining mRNA and vector-based vaccines in either order to see what kind of responses and durability we get. Vaccines that are incorporating new variants. So both of the companies are making vaccines now that are really focusing on Omicron and not bothering with the original strains, right? Because we know from experience now that as the new ones emerge, the efficacy goes down if you're specifically targeting the older strains of the virus. Intranasal vaccines, because we know that maybe perhaps mucosal immunity right at the site of where the virus is coming in might be really important to prevent transmission amongst people. And then combination vaccines, combining we may be getting an annual COVID shot with an annual flu shot. So these are all things that are in the works. The one thing I did want to point out to you all that are now going to be operationalizing the vaccination of the younger kids, if you missed it, there's a really excellent slide set. These are CDC COCA calls. They're clinician communication alerts, and they post the slides right after, which they did yesterday, and I put the link here. And you can read through a lot of other more interesting information, but I think one thing that's really why I was waiting for the ACIP meeting for them to highlight this, and they did, is that it's true that it's a 2-dose series for Moderna and a 3-dose series for Pfizer for a normal child. If it's an immunocompromised host, actually the primary series is recommended 3 doses for the very reasons that I just told you, that we know that it's very likely that you'll get that boosted efficacy with that 3rd dose. And there's a little bit of a difference in the interval between the 2nd and 3rd dose, which I'm not going to belabor right now, but I really highly recommend these calls in general, and this one in particular. There's a really nice slide set you can get online. Okay, what about therapeutics? Okay, I got to highlight here Ben Hainish in our division, who's also our head of immunocompromised host and transplant. He has been the point person for therapeutics from day one. That alone is a full-time job. It changes every 3 seconds. There's a difference in the name of the monoclonal we're going to use or the name of the antiviral, and he's been on top of it from day one. So he kind of gave me this slide. He said it's almost laughable. This is what we were doing in March of 2020. We had no idea how to treat this this virus, and we really could only focus on the kids that were in the hospital in the ICU. So we had an algorithm where they would call us on the pager. We had a whole nother call schedule where we took calls 24/7 on these kids. And if they had certain requirements over a certain amount of oxygen, we would try hydroxychloroquine. Well, we all know what happened with that. That ended up not being a useful thing. So there's a big red X on that. And then if they were mechanically ventilated, at the time, we had investigational remdesivir, and we used that. And that actually turned out to be right. So, that is now one of our most effective drugs. It's fully approved. We even use it on an outpatient basis. And then if they were really going into severe lung dysfunction or multi-organ failure, we were trying all kinds of things. So we had immune plasma, and that turned out to be of limited efficacy. It turns out that steroids ended up being standard of care. So anyone really that ill has really responded well to corticosteroids. And some of these other IL-6 inhibitors, which were used pretty heavily at the beginning, really have become second line. So a lot has changed. Now the focus has changed to outpatient prevention of disease for our highest risk patients. And we're really lucky to have oral agents that are antivirals. We have monoclonals that can be used, and we also have remdesivir. And all of these 3 can reduce the chance that someone at high risk will end up in the hospital by 80%. So we've come a really long way, focusing on having no idea what to do and only be able to help the sickest people to trying to prevent them from getting into the hospital to begin with. So I'm going to close in the last couple of minutes here with long-term outcomes, because that's really where our attention is now. I'm going to talk a little bit about the POCO, which is our post-acute sequelae clinic that is dedicated to multidisciplinary care and evaluation of these children. And then our big PICOS outcome study, which is a joint collaboration with NIH following kids for 3 years. So I think you're all aware of what is long COVID. And basically, if you see the virus come and go, and you see your initial symptoms come and go, some people continue to have symptoms over a period of 3 to 12 weeks, and some of them have them even for months afterwards. And these can be multi-organ and ill-defined. They can be fatigue, muscle pain, joint pain, problems thinking, but they can also be objective, like palpitations, fevers, abdominal pain, diarrhea. There's a whole large number of things being cataloged that can happen after a COVID infection. And we're now getting a little bit better at sorting out, well, which are those that are just left over from the initial infection in the first 4 weeks, which are new things that can happen in the 4 to 12 week period, such as MIS-C, and which are new things or persistent things that just don't seem to go away over a period of a month. And it's really this group that we call the lay community has called long haul or long COVID. And so Dr. Yantz here is one of our infectious disease physicians who really hit the ground running when we first started getting calls from families frantic for someone that would A, believe them that their child had these prolonged symptoms, and B, could do something other than just say, well, let's wait it out and see if you get better. So she put together this really core group, including infectious disease psychology, physical medicine, and rehab, as well as depending on the patient, ability to call and appoint person from GI, neurology, pain medicine, rheumatology, cardiology, or pulmonary. So all of these folks now have been working together for many months, addressing the needs of these patients and the families. And essentially anyone under 21 years of age or equal up to 21 years of age who's had these prolonged symptoms over 12 weeks since their initial infection is eligible. We have a nurse navigator who can then do an initial intake and figure out who needs to be present for their first intake appointment, which is generally a 2-hour appointment. And this happens every Wednesday. And Dr. Yantz actually gave me a little bit of data because I knew you all would be interested. And she just presented this at a meeting up in Montreal, because there's really nothing published really substantially about pediatric long COVID yet. So this was her first 70 patients that she saw. She mentioned that we are now booking into October. So there's just a big need for this and limited resources to see all these kids. But it is predominantly Caucasian children that are presenting. Now, whether it's truly Caucasian kids that are more affected or it's an access issue is another thing her team is looking at, because as I told you, we would expect that our African American and Hispanic groups should be equally affected by long COVID, if not more affected, because they're a bigger part of the burden of disease and hospitalization. The kids tend to be older, so median age is 12, although all age ranges, all kids in every age group have been seen. Slightly more females, mostly from the DMV region, but they're coming from many other states, as they are for our long-term study. The average days from the disease onset to when they come to ask for help in our clinic is anywhere from a month to 2 years, but the average is about 7 months. And the average number of symptoms per patient is 10. So they have many different types of complaints. And this slide, you can't read all of these, but I'm going to highlight for you the ones that are most common are fatigue, GI symptoms, lots of kids with abdominal pain, diarrhea, difficulty eating, changes in their weight. This has been something different that we've seen in the pediatric population than has been appreciated in the adult long COVID population. And we'll have to see if this bears out. And, you know, her group that is multidisciplinary, but also the other researchers in the country that are looking at this have really started looking at what are the questions for post-COVID? Are there new testing and diagnostic tools? Are there new pharmacological managements to address these symptoms? And, you know, what can we do to help these kids besides catalog, which has been the first phase of figuring out what to do to help them. So the last slide is really our pediatric COVID outcome study, which we call PCOS. And we are recruiting 1,000 kids now that are under 21, up to 21 years of age. We're having COVID survivors, whether they had asymptomatic disease that they didn't realize based on antibody testing, or whether they had symptomatic disease that was mild, if they were hospitalized, if they're in the ICU. All comers are eligible for this study, as well as healthy controls, which is super important in this 2 years of abnormal living for some of the outcomes that we're looking at. We need to have kids that have been through the pandemic that are not infected to compare them to these kids that have had infection. And they get a 3-year detailed evaluation every 6 months of their heart, lung function, quality of life, neurodevelopment, and mental health. We use a variety of validated surveys that are age matched, and we're getting some really interesting preliminary data that I can't share with you in this talk, but maybe in another talk sometime in the future. We also have built a very powerful biorepository from which we are doing antibody studies to see what happens to pediatric antibody responses over time. Looking at the genetics of disease, can we figure out which groups based on genetics are more likely to have one or more of these severe phenotypes of disease? Looking at those T-cell responses, which I mentioned to you earlier, may be really important for durability. And a variety of other studies that researchers will have access to. So to date, we're about 50% into our enrollment, and we're about 50% enrolled. There's been a lot of interest. We are getting all age groups. We have a nice match of healthy controls to survivors. So this is going to be a really important data set as we move forward over the next 5 years. So, there's no way we could possibly acknowledge really every single person in the hospital that has had some part of what we've learned about COVID in the last 2 years. But these teams that really have come to the plate for every single emerging infectious disease, we've seen this over and over again over the 15 years I've been here, whether that was Ebola, whether it was Zika, acute flaccid myelitis, and now, COVID and MIS-C. These groups come together and really, rise to the occasion when we're facing something that's unknown. So it's really been a privilege to work with all these folks. And I think I'll end there. I don't know if we have time for questions or not, but yeah, we do.
Yeah.
Thank you, Dr. DeBiasi. To stay on track, we'll probably start with this question regarding long COVID. One of the participants said, we've had patients complain of symptoms like long COVID, but only after the vaccine. Do we have any evidence that the vaccine itself, like the spike protein, is playing a role in this, or should we be worried about that?
Well, I think the first thing is it's hard to know, right? Because unless you've done antibodies that look at both on your patient so you may say, well, I'm assuming this is someone who thinks they've never had COVID and then got vaccine.
Yes.
But what we have found is a lot of people have had COVID, even though they don't think they had COVID, because you can have asymptomatic or mild infection. So I'll give you an example. In our study, we have a lot of people that come that are enrolled as healthy contacts. They think they've never had it. And as part of the enrollment, we do antibodies, but we do it not just to spike, which is you can get that from natural infection or vaccination. But if we do it for nucleocapsid, the only way to get nucleocapsid antibodies is if you've had natural infection. And we've had tons of kids that thought they were a healthy contact that we then had to cross over into, oh, actually, I had infection. I just didn't know it. So I guess that would be my first response is, those kids that you're saying it happened only after vaccination, it's highly likely that they, although they've been vaccinated and did not have symptoms, they actually probably have also had COVID infection at this point. And some estimates are up to about 75% of kids have had infection at this point. But if the question is there a signal so far that vaccine is more likely to trigger long COVID than natural infection? The answer is absolutely not.
Okay, great.
Yeah.
They also want to thank you and your team for the excellent work you've done throughout the pandemic.
Thank you.
There's also a comment related to long COVID about I hope we just continue to study this because one of their family members had neurological effects after the 1919 flu 4 decades later, developed early onset Parkinson's. So they hope you continue this work. There's one specific question related to Paxlovid, and if you think it will be offered to those less than 12 or recommended to healthy versus non-immunocompromised patients in the future.
Yeah, I don't have inside information. Right now, the caller's correct, or the questioner is correct, that it's only for kids over 12. And I don't have inside information about if the company is actively doing research or going to ask for approval under that age group. So I don't know.
Okay. And the final questions are related to, we have a lot of families, I'm sure many people here too, have families that are coming in, they're like, I have younger kids, my kids have already gotten COVID, I don't really need to get the vaccine. One of the questions specifically around how you were saying the vaccine seems to prevent against MIS-C, is there any other recommendations you have when you're talking to families, especially, it sounds like CNN reported last night that, the vaccine doesn't cover the new variant. And so yeah, any comments you have there?
I mean, the vaccine questions are always tough because if someone says, well, can you tell me I'm not going to get COVID if I get vaccinated? No, we can't say that. We do know for sure, though, over and over the last 2 years and more, that it's the group that is not vaccinated that even if it's a low risk that you're going to be hospitalized, it's that group that gets hospitalized. So I always talk about it like a safety belt. We drive to work every day. I drive an hour every day plus. And the chances are I'm not going to get in an accident, but I still wear my seatbelt every day because I've had 2 major accidents in the 15 years I've been doing that drive. And if I didn't have that seatbelt on, I would have been probably not up here, talking to you about COVID. So, when we talk about vaccines, it's not to completely prevent the event. It's to prevent what we know can be the severe and luckily in pediatrics, somewhat rarer possibility that they'll be hospitalized or die. But if you have a safe product that we know works, it makes sense to use it.
Terrific.
one of the slides that you showed for the pediatric vaccination, the Moderna one was 25 microgram. I believe it is 10.
Oh,
3
I
and
may-
10. You
I
had 3
am-
and 25 because the
I
adult
may
is
have
30.
I may have to check that again. I'm
Because
sorry
the
about that.
adult is 30, I believe. Again, I'm not like
I'll check the
doing it
COGA
day in and
slides.
out, but.
I know Pfizer's definitely 3. And
Yeah,
I'm
so
pretty
I
sure
think it is
Moderna's
3 and
25,
10,
but it may be
not 3
10.
and 25.
I don't know if Claire's got her computer out.
Moderna's 25 micrograms.
Yeah. Yeah.
So it's higher than
What's the pediatric one then? 5 to 12.
it's 10, which is interesting.
5 for daily?
So as the country has moved more and more towards home testing
Yeah.
for COVID, how are we keeping track of what the real incidence is? Because I feel like the numbers are going down when you look at the charts, but when I look at what's going on in our office, we're still seeing gobs of COVID.
Yeah, definitely the percent positive tests is a very much an under reporting, but what we know is that, you know, we can follow the hospitalizations. That's what it is, right? And we just haven't seen those surges of hospitalization. So even with these 14% still positive tests, it's probably much higher than that based on what you're saying. You're seeing these kids that get tested at home that we don't capture. So let's say it's 50% actually that are positive at this point. We still see that the hospitalization rate is staying very low. So if anything, we're underestimating how little hospitalization there is associated with so much circulation of the virus. But there's still a ton of virus circulation right now. Okay, thank you.
I want to thank Roberta, Dr. DeBiasi. You know, in fairness, this has been trying for all of us. There are, all of you are heroes for really being on the front line and really helping to manage this, but it just helps having some great teamwork and great leaders to sort of help keep us focused and help answer the questions for which there aren't easy answers. This is still a work in progress for all of us. I think there's some glimmers of hope, and hopefully we will continue to see more and more of our worlds moving back to where we want them to be.